I think let us start. We have 38 participants. Let's not waste time.
Yes, sure. 38 are enough.
Yeah. So, a very good evening to you all once again. I'm Dr. Afreen, also known as the White Coat Mama. I hope you all are doing very well. And yeah, Eid Mubarak to you all. So, how was your Eid? Let's keep it a bit interactive. We're just not with not just us talking. Let's have you guys talking as well.
Yes.
Yeah. So, how was Eid, everyone?
It was good.
Alhamdulillah, great,
You
ma'am.
can turn off your mics. We cannot hear you.
Yeah. Turn on. Yeah. Yeah. So great. I think some of y'all answered. Yeah. Here we had a long weekend. UAE loves giving long Eid holidays for everyone. So it was great. So now that we are back from vacation, let's get back to the grind. And yeah, without taking much time, before we start today's class, I think let me give you a quick brief intro about our platform, which is Dr. Afreen's Academy, and what we offer, and give you a gist of what to expect in today's class. So, for those of you who are new here, Dr. Afreen's Academy is basically a training platform for prometric GP exams, general practitioner exams, dental GP exams, pediatric and family medicine specialist exams. We are, inshallah, planning to add more specialist courses as well. In fact, working on them. So, we started our platform last year and have enrolled around more than 500 plus doctors already with very high success rate, alhamdulillah, and numerous success stories. You'll find them all. You will find them across our socials, website, and WhatsApp groups. So it's a premium training platform trusted by doctors globally. Our study courses are curated by doctors, exclusively by doctors, from the doctors to the doctors, general practitioners, specialists, and dentists, respectively, for respective courses. And our study programs basically caters to all. This is for those of you who don't know. That's why I'm giving you a introduction about my platform and what we do. So our GP study program caters to all Gulf countries. It's not only limited to DHA or HAD or MOH. It caters to other Gulf exams as well, which is DHA, DOH, MOH, SMLE, OMSB, Qatar, exam QCHP, KMLE, NHRA, as well as for PLAB 1 exam. It's also helpful for PLAB 1. We have online GP crash course, which is we are starting our second batch of crash course today. We have already finished one, which was just before Ramadan, as well as online MCQ subscription. For those of you who are not interested in online classes, you can join online MCQ subscription. So our crash course program is basically a 2-month long program. It's named crash course, but it is not really a crash course because we extensively cover all the topics that are asked for the exams. Specifically targeting GP exam topics, important topics and recalls, etc. So you will have online live classes covering uh, all high yield exam topics, GP exam topics, recalls from the 4 major specialities. So the 4 major specialities are internal medicine, general surgery, obs and gynae, pediatrics. So these are the 4 major specialities that will be tested in your exams, GP exams. So internal medicine, you have subspecialties. Can you all name the subspecialties for me that comes under internal medicine?
Cardiology, gastro,
Yeah,
rheumatology,
right.
endocrine,
Yeah. There's cardiology, there's
nephrology,
endocrinology. Right.
nephrology.
Yes. Yes. There's gastro, there's endo, there's cardio, there's emergency medicine, pulmonology, infectious disease, there's hematology, oncology, nephrology, neurology, rheumatology. So these are the subjects that come under internal medicine. So the uh, major weightage is given to internal medicine. Second is your OB-GYN, obs and gynae. Third, general surgery, and then pediatrics. So these are the 4 major specialties that will be tested. And for DHA, GP exams, you will be given the result at the end of the exam. So you will be given the percentage as well in how much you have scored in each of these. So you need to get an aggregate of 60%. It is not 60 in each. It is an aggregate of 60%. So that is what they wanted to score. So you will have our GP in our crash course, you will have 2 classes weekly. So it's not exhausting. So it's only 2 classes per week mostly Mondays and Tuesdays, which will be 6 p.m. GST, weekly for 2 months, which is 8 weeks. So, in a span of 8 weeks, we will try and cover these four subjects. We'll keep 2 weeks for one subject. So, that's how we normally do, covering all the important exam questions, topics, recalls extensively. Along with the classes, you'll get 2 months of online MCQ access, complimentary. Online MCQ access, it's a comprehensive self-study materials. Except for online MCQ, online classes, you will get everything else, which is subject-wise. There are 25 subjects, by the way. So, which includes all of these four specialities that I mentioned. You have ENT, Oftal, and many, many others of ortho, ethics. Ethics is another important subject that you need to focus on. Ethics, psychiatry, this is another important, and epidemiology, there's genetics, there's so much to read for GP exams. So you will get all of these in the form of online MCQ subscription with detailed explanation. There's golden recall file, there's subject wise MCQs, subject wise recalls, I'm sorry. So apart from the MCQ plan, you get subject wise recalls as well, which is specific for the exam. And you have theory, high yield, important theory review points. You get that as well. You have 12 mock tests, time based mock tests. There's picture images. You get a lot of picture images. So maybe in the coming classes, I would like to keep one class open. I would want to take it myself. One class open for only picture images, subject wise. There's medicine. In medicine, you get all chest x rays and you get ECGs, you get CT scans, and all of those things. And in OB-GYN, you get a lot of CTGs. So they'll give you a picture of CTG and they'll ask you to uh, identify it. What is the diagnosis? Read the CTG and things like that. So you have so much of picture images coming for your exam. So you need to be thorough with that as well. So that's included in our online MCQ subscription. So along with that, in the crash course, you get one-on-one personalized mentorship, which is we will be accessible for you. The coaches will be accessible. So you can ask your doubts, questions, queries on the WhatsApp group, on the crash course group, of course. So we will answer it for you. And this is our second batch for Crash Course. Most of our first batch students, those who have ever has written the exam, have passed, alhamdulillah, with good scores, by the way, not just passed. But that doesn't really matter if you have got all they need is a pass score. Your score doesn't really matter for your DHA or whatever exam you're giving. So just passing is enough, but they have got a good score. And the others who are yet to sit for the exams, uh, I mean, of course, they have not written the exam, so we are just hoping they pass too. And today we are starting with pediatrics. We have Dr. Maruf today, who's our coach for today. He's a general practitioner. He has passed USMLE Step 1 and 2 with a very high score. And he is expecting to get matched into US residency very soon. Right, Dr. Maruf?
Thank you, Dr. Afreen, for this introduction.
Yes.
Hello, everyone.
Yes.
My name is Dr. Maruf, and I am here.
So he's working in, I think, pediatrics. He told me he's working in the pediatrics department and he's a general practitioner and he has passed his steps. He's planning to get matched into US residency inshallah very soon. And we are glad to have him on board as our coach. And I will be taking few subjects as well in the coming weeks, inshallah. And I would love to give you some tips and tricks on how to approach exam questions and how to rule out the options and how to get to the correct answers and how to effectively and smartly do your exam prep. So if you're joining the regular crash course batch, I'm sure you'll enjoy the coming classes and more importantly, it'll greatly benefit you. Um, Not just pass your exams, but also I think become better in your GP practice because this is what is needed. And when you get into if you get a job here, you will have an interview. I'm not sure if you're aware of this. There will be an interview wherein you will be asked all of these questions. So if you're getting into gynecology, you will be asked GP questions, and if you are getting into emergency medicine, you will be asked questions on internal medicine and emergency medicine, ICU, and all of those things. So it's not just sufficient to pass your exam, but it's equally important to understand and there is so much more that happens after you pass the exam, especially at the interview. So it is solely based on that, whether they give you a job or not. So it's important to understand the concepts, and here we focus on mastering the key concepts, tackle challenging questions, and refine your approach for the exam, as well as the interview that takes place later. So I would advise you all to stay engaged, be attentive, ask as many questions as you want during the session, or throughout the classes that we are going to conduct. And you all make the most of what we have to offer. And like I said, I'd like to keep one of my classes, one more class in the future. Maybe in the coming weekend, I would like to take one subject for you guys. Maybe OB-GYN, because that's important subject, or emergency or something. We will keep you all updated regarding the subject, date and time. All of those things will be announced in the groups, so stay tuned. And if you plan on joining a regular batch, we are running a 10% Eid offer on Crash Course until this weekend. Details will be posted in the groups again. So yeah, that's pretty much it from me. And so without further ado, let's get started with pediatrics today. Dr. Maruf, over to you. Yeah, the stage is yours. So I hope you guys have a great time. And if you have any doubts, please clear it. And maybe towards the end or something, you can ask if you have more doubts or questions. Yeah, so let's get started.
Hello, everyone. This is Dr. Maruf here. First of all, I would like to thank Dr. Afreen for giving me this amazing opportunity to teach you guys about pediatrics. A little bit about my background is that I am working as a physician in Department of Pediatrics in a secondary care hospital here in Pakistan. And I have cleared my USMLE step 1 and 2, and inshallah next year I will be applying for the match cycle.
Yes, Dr. Maruf, I think let's start.
Yes, we should jump right into it.
Yes.
So we
Yes.
have our first MCQs here. The format we are gonna follow is that we will present you with an MCQ scenario, and whatever topic is present in this MCQs, we will try to explain entire that topic to you in 2 or 3 slides. Not only just that topic, but we will also teach you how to exclude those other options that will try to distract you in the exams. Okay. So here we have an 8-year-old boy who is brought by his mother to the emergency department with bruises on his lower back and a left shoulder dislocation. And the child currently lives with his stepfather. The young boy is quiet and makes no eye contact while in the conversation. What is the most likely diagnosis? So, in this scenario, what do you think is the diagnosis? Is it malnutrition? Is it thrombocytopenia? Is it non-accidental injury? Or is it hemophilia? When we look at the question stem, it states that there are bruises on his lower back, uh, and there is a left shoulder dislocation. So immediately we have two physical injuries, and the child currently lives with his stepfather. I want you all to know that whenever they mention in the question stem that the child is accompanied by his stepfather or stepmother or his maternal aunt or uncle, uh, basically meaning that the child is not accompanied by his blood relative. So in that scenario, I want you to think that they are hinting toward non-accidental injury. Because in those circumstances, parents are not willing to accompany their child to the emergency department. Okay. And the other hint that they are giving is that the boy is quiet and he makes no eye contact while in the conversation. So it is also another important diagnostic clue, okay, towards the non-accidental injury. When we look at the other options, they are like malnutrition. It is irrelevant here because they have not mentioned about anything like BMI. And when we look at thrombocytopenia, there is also no clue about his number of platelets, and also not hemophilia. So When we talk about non-accidental injury, the only other differential diagnosis that comes in our mind is actually osteogenesis imperfecta. Why is it so? Because both non-accidental injury and osteogenesis imperfecta have multiple fractures throughout the body. Okay, it is obvious that if a very young child is going under to physical trauma, he will likely experience bone fractures. Okay, same is the case with osteogenesis imperfecta, which is a disorder of bones basically. Okay, the bones are very brittle, and the collagen which is supposed to be present in the bone is not there, and is chemically different from the normal type of collagen. So the bones break very easily in that circumstance also. And the differentiating feature that will help us differentiate it from osteogenesis imperfecta, it would be like in the scenario of osteogenesis imperfecta, they will mention about his blue sclera. Okay, they will clearly mention that the child has multiple fractures in his body and like his sclera are blue, or they may even mention that he even has some kind of hearing problems as well. We have prepared a slide on osteogenesis imperfecta as well, and we have clearly mentioned in that whenever you see two of these conditions accompanied by some bruising throughout the body and like multiple fractures in the bones, then you have to think about osteogenesis imperfecta. Okay, if both of these clinical features are absent and the child only has bruises that are in the various stages of healing, along with the multiple fractures throughout his body, then you have to really think about non-accidental injury. You may think that this slide is not that important because it doesn't appear to be important. But the thing is, we are seeing more and more questions about non-accidental injury nowadays on our real exams.
This
Uh,
is a
ma-
very important, and you will definitely get one question on this. NAI. This is a
yes,
very, very important question for DHA exam, UAE GP
yes,
exam. This is a 100% question in pediatrics.
yes. So we have to really focus on all of its aspects, that how will the child present and what the management steps that we have to take in this regard. So as mentioned earlier, the most prominent symptoms that would be present is that there will be bruises that will be in the various stages of healing present throughout the body of the child. Like you will examine his abdomen and there will be one bruise, then you will examine his arm or forearm, there will be another bruise, then you will examine his thighs and there might be another bruise present there as well. Okay, that will be present on physical examination. And in some cases, they might also mention about the retinal examination. In retinal examination, the very, very specific finding about accidental trauma will be retinal hemorrhage. So imagine that a child is being shaken very hardly by a mother or his father or any other adult. In that case, the vessels that are present within the retina, they will get sheared, and there is no other like condition that will have retinal hemorrhage in this age group. We can see retinal hemorrhages in adults in cases of like diabetes or hypertension, but in a very young child, whenever you see retinal hemorrhages, please think about non-accidental trauma as being the most likely diagnosis. Okay. And if they mention in the CT scan of a child that has a multiple fractures, and the CT scan says that the child has subdural hematoma, in that case, you may also think about non-accidental trauma. But I want you to focus on the major two clinical signs that would be bruises in various stages of healing and multiple fractures that will be present throughout the body. And if we talk about the fractures, the most likely fractures that they will try to mention in the question stamp would be rib fractures, or they may be fractures of even skull bones. Okay, but you are more likely to see about the rib fractures. Okay. And as mentioned earlier in the question stem, the child will be brought by a stepfather or boyfriend, but not by his real parents. Okay, that will give you an important clue about this diagnosis. So now we have set the bar that this child has non-accidental trauma. What are we gonna do next about it? What do you guys think? A child comes with multiple bruises present throughout his body, and he's crying very loudly, and you suspect that this is non-accidental injury. And what should we do next? What would be our next best step in his management?
Get social services. Yeah.
First, we will call his or her blood relative, mother or
Hmm.
father.
No, what would you immediately do in this scenario?
Treat the patient analgesia.
The
Good.
the next step in management in that case would be like we have to admit the patient immediately, and we have to perform his whole body skeleton survey to get the real picture of how many fractures are there throughout his body. Okay, and we have to do it immediately, because if it is not addressed immediately, and the patient may just die right there. Okay, because we do not know exactly that through how much trauma this child went, and we really want to document that all of his injuries at the time of examination. Okay, and then we have to inform the parents directly or any relative that he is accompanied by that we are suspecting non-accidental trauma here. The child may be undergoing some abuse, and we cannot hand over your child just after the physical examination, and we cannot let you go home. We have to admit him, and we also have to inform Child Protective Services about this suspected abuse. But that would be in clinically, that is just after we have done skeleton survey. Okay, after we have confirmed that this is a case of child abuse. Are we guys clear on this?
Yes, sir.
Okay. So the take-home points about non-accidental injury is that you have to really focus on physical examination, focus on words like bruises in multiple stages of healing, multiple fractures, retinal hemorrhages, subdural hematoma, and maybe even burning injuries throughout his body. And after suspecting non-accidental injury, we immediately have to admit the patient, and we have to perform his whole body skeleton survey and then inform his parents or any relative that we are suspecting child abuse, and we have to inform Child Protective Services. Okay, so that is your first topic of this presentation.
Here,
If
Dr.
you have
Maruf, I would like to add here, if you don't mind. Every
Mhm.
question to all the listeners, every question basically gives away one key word, one key point, a clue.
Yes,
Every question. So here you will in this very rightly, like Dr. Maruf said, you will have to look for the key features. So when you're reading, you will have to read the clinical features, diagnosis, investigation, management, and everything. When you're reading it, look for the key points, clues. In this, they have given like fracture, there's a fracture, there are bruises. So like he very nicely pointed out and ruled out the other options, that is the way to go about. And even if you don't know the answer, this is a very easy method to come to the correct answer, right? Even if you don't know if
yes,
it is a NAI, rule out the other options and look for the clues. In this, there is fracture, there is bruise. And can you come to the question, doctor?
yes, there it is.
Yeah. So here are the keywords. What are the clues here? If you can just see. Yeah.
The main clue here is that there are bruising on
Bruises.
his
Right.
lower back and a left.
Dislocation. Yes, these are all very irrelevant. You cannot find this
Yes,
in one particular disease, like
yes,
osteogenesis imperfecta. In that, it is fractures, but you will not find bruises in that. So here, it is all haphazard. They have all different. The patient can come with retinal hemorrhages. The patient can come with head injury. At the same time, he can have fractures. So where everything, if all different symptoms fit under NAI. So it is also called as battered baby syndrome. So this is another option they can give you instead of
Yes.
NAI, battered baby syndrome. This is a very important question in all the GP exam, and you will definitely find one in this, in one of your exams. So the X-ray, yes, skeletal survey, and admit the patient, refer him to or call Child Protection Services and call his parents. So these are the things that you will do, and this is how you rule out and get to the correct answer. Okay, if it's clear, we can move on to the next. If you have any doubts, you can ask.
Should we move forward, guys?
Yes, sir. Yes,
Okay.
sure.
Okay, so a 4-week-old female infant presents to the emergency department with vomiting after every feed. Okay, vomiting after every feed, and that is at the 4 weeks of age. You have to really focus on that point. I will explain it later why. The mother describes the vomiting as projectile and non-bilious. Okay, you have to also focus on these two words very closely. The child is also constipated. On examination, there is right-sided olive-sized abdominal mass on palpation. What is the most appropriate next step of action? So, what do you guys think about is diagnosis? Because whenever there is a question about what is the most appropriate next step of action, the first thing that you should do in your mind is that you have to build a diagnosis in your mind. If you cannot build a diagnosis in your mind at that point, you will have a lot of difficulty in proceeding what to answer about that question. So first, you should focus on the examination findings. Findings that are mentioned in this question stem. The mother describes the vomiting as projectile and non-bilious. Okay, the vomiting is projectile. Usually in a question stems, whenever the vomiting is projectile and non-bilious, it means that the vomit is coming from the level of stomach. Why so? Because if it is coming from beyond the point of stomach, it should be bilious, right? It should be of green color, because we all know that the bile is mixed up with the chyme from the stomach after this first part of duodenum. Okay, so if the if the vomitus is not contained with that green colored bile, it means that it is coming from the level of stomach. Okay, so immediately it tells that the pathology should be at the level of stomach. And on examination, he has mentioned that there is a right-sided olive-shaped abdominal mass on palpation. Okay, so there is a very common and very famous childhood pathology that is called wait a just so there is a very common childhood pathology that is called hypertrophic pyloric stenosis. Okay, and the most important point to remember about this pathology is that it will present at around about 4 weeks of age. You have to really memorize this point, because whenever there will be a diagnosis of hypertrophic pyloric stenosis, the age that would be mentioned in the question stamp would be around 4 weeks of age. Why is that? Because the obstruction that is developing at the level of pylorus, it usually takes about 3 weeks to develop. It usually takes about 3 weeks for the smooth muscles in the pyloric region to develop. Okay, uh, it means that whenever a child is born, there is no stenosis, and the pyloric muscles at that time are normal. And whenever the risk factors of these conditions are present, I will discuss the risk factors in the next slide. And it will take for the child about 4 or 3 weeks for that stenosis to develop. Okay. So whenever you see a child at 4 weeks of age with projectile and non-bilious vomiting and olive-shaped abdominal mass on abdominal examination, you have to think about pyloric stenosis. These are very specific and very important examination findings that are associated with this condition. So in this, you have diagnosis in your mind at this point. Okay. So what is the most appropriate next step of action? What do you guys think we should do? Should we do abdominal ultrasound? Should we do abdominal x-ray? Should we perform serum potassium levels, or should we give fluids right away? What should we do?
Serum potassium levels.
Yes, you are right. And why do you think is it so?
Um, because the I think that's going to be the next step. But to confirm the diagnosis, then it's going to be to do the ultrasound.
Ultrasound.
Ultra-
So let me explain why should we perform serum potassium levels as appropriate next step of action. So the thing here is that whenever there is pyloric stenosis, the connection of stomach from duodenum is almost completely obliterated. Okay, no fluid, no feeding is going from stomach to duodenum, and this essentially means that the child is dehydrated. And whenever a child is dehydrated, there is a lot of possibilities that an underlying electrolyte imbalance is also there. Okay, so we have to immediately perform serum electrolyte levels to confirm that we have an electrolyte imbalance, and we have to first correct those abnormalities, and then we have to move towards giving him fluids. Okay, if we give fluids right away without seeing him checking his potassium levels, he may just go into hypokalemia and may have a very lethal cardiac arrhythmia and just die right away. Okay, so immediately we have to perform serum potassium levels, and if most likely you will see an abnormality. Question may also even mention it that his potassium levels were low, and what would you do next now? In that case, we have to give him intravenous fluids. Okay. And if question asks you what is the next step, best step in diagnosing this condition, that is very obvious that it is going to be abdominal ultrasound. Okay, because ultrasound is like the best investigation that is present around for abdominal pathologies, especially in this age group, because abdominal ultrasound is really safe. There is no side effect associated with performing examinations with abdominal ultrasound. Okay. Any questions about
Doctor,
this condition?
question: if there won't be any option like serum potassium level, and we have the
Mhm.
rest three options, which one should
Mhm.
we go for first? As you mentioned that IV fluids as well as ultrasound. So which one should we choose from?
Okay. In that condition, you have to focus that if the examiner is mentioning anything about his hydration status, if the question mentions that the child is very dehydrated, his mucous membranes are dry, his skin turgor is very poor, and he asks you what is the most appropriate next step of action. In that case, you have to pick about intravenous fluid. Okay. And
Okay.
if these findings are not present and the child appears to be clinically stable, because by stable I mean that he is not dehydrated, then you can then you can go with abdominal ultrasound. And it is very unlikely that you have to choose between these two options on real exam. Okay, he will
Okay.
clearly
Thank you.
mention that if he wants to proceed with a diagnostic investigation, or if he wants to proceed with a management step, that is treatment step basically.
Got it.
See the general pattern that you have to keep in your mind, that conditions that are immediately fatal, there is no time for you to do investigation at that point, right? Because it is easy to just diagnose those conditions based on physical examination for just a time being, and proceed with management steps first, and then we can come and diagnose that condition for all that kind of paperwork, but later at that point
You
you
should
will see
always
this.
remember I'm sorry. Yeah. You should always remember the ABCs in any
Yeah.
question. If there is any immediate emergency, you should just treat that first. What are the ABCs? Airway, breathing, and circulation. In this case, if they have mentioned, I think the patient is dehydrated. That is why you have, if like Dr. Maruf mentioned, if there is poor skin turgor and if there is extreme dehydration mentioned in the question, clinical features mentioning extreme dehydration. So first thing you will do is give IV fluids. irrespective of the diagnosis, because ABCs don't change, the treatment for ABCs don't change in any diagnosis. So that is the first thing you should do in that scenario. If the patient is clinically stable, then yes, you should do the investigation and try to find out what the diagnosis. But first is management, ABC, airway, breathing, circulation.
Okay. So I will just repeat about this specific pathology because it is very important and very likely that you will see this on your exam day. Whenever you see an olive-shaped abdominal mass on abdominal examination, the examiner is trying to make you think about pyloric stenosis. Okay, and that too with around 4 weeks of age. As I mentioned earlier, that it is the time that is usually taken by pyloric smooth muscles to be hypertrophied. Okay, so you have to really check what is the age of the patient and what are you seeing on his abdominal examination. Plus, if he is kind enough, he may also mention the words like projectile and non-bilious vomiting. Okay, that is just he is giving you diagnosis right away. But the only thing you have to do is just you have to be familiar with these terminologies. Okay, if you are not with these terminologies, you are not familiar with these terminologies, you may face difficulty on your exam day. So any other questions about this pathology? Okay, we should move forward. And presentation, I have already told you about what is going to be most likely presentation. And it is diagnosed with abdominal ultrasound because it is really safe and excellent at picking those hypertrophied pyloric smooth muscles. And what I missed earlier is that vomiting, if we talk about vomiting in any age group, the most likely ABG's abnormality that we are going to see is metabolic alkalosis. And that, if I specifically mention, that would be hypokalemic metabolic alkalosis. Okay. I will just repeat it. Hypokalemic, hypochloremic metabolic alkalosis. That is most likely ABG abnormality that you guys will be associating with vomiting. Why is that? Because whenever we vomit, we are just essentially losing our stomach acid. Okay. Uh, Whenever we lose our stomach acid, it is very obvious that we are going to get alkalotic in our pH levels. Okay. And stomach juice also contains a lot of chloride levels. So our chloride level is going to fall, and it also has a lot of potassium in it. So these two conditions are also going to accompany. And that is the reason why the correct answer was we have to check about potassium levels. Okay. Because vomiting is associated with loss of potassium and loss of chloride ions. Okay, along with metabolic alkalosis. But we do not need to correct this metabolic alkalosis by giving him uh, chemicals like sodium bicarbonate, because whenever we give fluids to these patients, their pH automatically falls down unless until it is very severe pathology. Okay. And then after stabilizing the patient, giving him fluids, correcting his electrolyte abnormality, we just have to simply refer these patients to pediatric surgery for pyloromyotomy. And it is very important because this thing is not going to just disappear. We have to perform pyloromyotomy, and it needs to be surgically corrected. Okay. So we have our next scenario. A 4-year-old girl presents to the emergency center with difficulty breathing and stridor. Okay, she has a temperature of 39 degrees Celsius, and the parent states that the child has been in her usual state of health but awoke with a hoarse voice and difficulty swallowing. Okay, you have to focus on these features: hoarse voice and difficulty swallowing. They tell you that she has not been immunized because they are afraid of the side effects of the vaccination. What is the most likely diagnosis? Is it cystic fibrosis? Is it some kind of immunodeficiency, or these are recurrent aspirations, or is it acute epiglottitis? I think it is very obvious when you compare these options that the diagnosis acute is acute epiglottitis. Why so? Because cystic fibrosis, whenever there will be a scenario of cystic fibrosis, the examiner will be mentioning in the scenario that the child has a history of recurrent upper or lower respiratory tract infections. Okay. Similarly, with immunodeficiency, the child will be having history of multiple infections and recurrent aspiration. This is just he is not even trying to distract you with this option. Okay. So we focus on acute epiglottitis, which is a very, very important uh, exam topic. It is not that important clinically because we know in almost every country the vaccinations against Haemophilus influenza are routinely administered to every child that is born. Okay, so we may not encounter this scenario clinically a lot, but we do encounter acute epiglottitis in exams. So, Haemophilus influenza is basically a bacterial infection that is caused by type B Haemophilus influenza. Okay, that is basically gram-positive coccobacilli, and it is encapsulated organisms. So, in this question, if you try to read it again, the examiner has mentioned that she has not been immunized. Okay, whenever in a question stem you see this line that the child is not immunized, the examiner is trying to ask you to focus on these infectious diseases that are very common, and almost every country has a vaccine that is administered to a child whenever he's born. Okay, so basically, acute epiglottitis is one of those conditions. It is it may be very lethal clinically, but if a child has been administered a vaccine against it, then there are almost zero chances that he will be exposed to this bacteria. So, if we talk about its presentation, uh, let me just focus on here. In acute epiglottitis, as name says it, where is pathology most likely lying in this condition? Obviously, that is going to be at the level of glottis. Okay, epiglottis basically. So your epiglottis becomes inflamed in this condition. Okay, it means that your upper airway is getting squeezed. Okay, your airway is getting squeezed, and what would it lead to? As mentioned earlier in this question, it would lead to hoarse voice and dysphagia, that is basically difficulty swallowing. You can imagine that if upper airway of a child is inflamed, obviously he's gonna get a hoarse voice, okay, and difficulty swallowing. And very important physical examination finding is that he's also gonna get a stridor. Stridor is, for those of you who do not know, stridor is basically an harsh breathing sound that is also audible to you even without auscultating the patient. Okay, the child would be lying on his seat or lying on his bed, and a very harsh breathing sound would be present, just like a whistling sound. Okay, that sound would be clearly abnormal if you hear it clinically, and you will immediately tell this that this patient is having some kind of abnormal sound. And if it is audible to you without stethoscope, we call it as a stridor. Okay, so stridor is present in conditions that lead to inflammation of upper airway. Okay, and we all know from the anatomy that upper airway as that epiglottis is included in that upper airway. So if it is inflamed, and we are going to see a stridor here. Okay, so, and one more thing I would like to mention here is that since we know that epiglottitis is a very fatal condition, it would lead to very high temperature on physical examination. Not only just very high temperature, but also that the child will be in respiratory distress. Okay, the respiratory distress is so important in this case that the next step we perform in these type of scenarios is that we have to check that is the child is in respiratory distress, because if he is in respiratory distress, we immediately need to perform endotracheal intubation right away. Okay, this is very peculiar. You need to be familiar with this because there are very few infectious conditions in which we have to perform endotracheal intubations right away. And epiglottitis is one of those conditions. And the reason being is that there is such severe inflammation of soft tissues of epiglottis region, and they will all lead to narrowing of trachea and obviously pharynx. So, if a child presents with increased respiratory rates and examination findings are mentioned that state that he has subcostal recessions, or if he is using accessory muscles of respirations, or if his respiratory rate is greater than 35 or maybe even 40s, and the child is present in tripod positioning. What is tripod positioning? And it is a position that is maintained by the children in which their head is leaning forward, and they are in this position to oppose that to oppose that swelling of the pharynx. Okay, whenever they will be leaning forward, it just means that he is in respiratory distress and the child is trying to cope with that distress by just leaning forward. And drooling of saliva may also be mentioned in question stem, and it just also means that his airway is just narrowed and he's having trouble difficulty swallowing. Okay, so whenever these features are present, they just mention they are just trying to say one thing to you. What is that? It is that his airway is narrow and you immediately need to take care of it by either performing endotracheal intubation. And one more thing I would like to mention here is that we have to just perform a single attempt at endotracheal intubation in case of epiglottitis. Why so? Because again, the reason is same. The inflammation is so severe that even intubation becomes very difficult to perform. So if a single attempt fail, you do not need to perform a second time. So can you please guess what would be most likely next step in that case if endotracheal intubation fails? And the question stem is clearly mentioning about acute epiglottitis. Can you please guess?
Incubation.
Anybody?
Oh, thyroid.
So in that
Tracheostomy.
case, I didn't get that. What did you say?
Tracheostomy, sir.
Sorry, your voice wasn't clear enough.
Tracheostomy, sir.
Yes, yes, yes. You are absolutely right. So, in that case, in order to bypass that swelling of the epiglottis region, we have to perform emergency tracheostomy. Okay, so what is tracheostomy? It is basically that we perform an incision below the level of epiglottis, and we will directly insert an airway through that opening so that child might able to be breathe and his swelling is bypassed. Okay, the point that I was focusing so much here was that the swelling and inflammation of this epiglottis region is so severe that the most appropriate next step in this case becomes either endotracheal intubation, and if that fails, then we have to really think about emergency tracheostomy. But first, we have to perform endotracheal intubation. Okay. And if endotracheal intubation has been performed and he's asking about what is the investigation that we can do right now, that would be lateral x-ray of the neck. And it is also mentioned here, and the very specific finding that you will see in on x-rays in these cases is that you will see a thumb sign. You can see green arrow here, and it is indenting upward, and it just represents the whole inflammation that is going on in this region. Okay, are you guys having a look at this x-ray? It is the only investigation that you need to know about this condition. Okay, and treatment is that we give intravenous antibiotics that are most likely intravenous ceftriaxone, and I think so, yes, we have to just treat it with ceftriaxone. Okay, so I will just repeat the most important points about this condition is that a child with history of uh, can you please turn off your mics, please? The important feature that we are going to see with acute epiglottitis is that we will see very high temperatures along with a resting stridor and drooling of saliva and difficulty speaking or even a muffled voice or even a change in voice. All of these features are just present because there is a lot of inflammation going on in this pharynx and epiglottis region. Okay, so any questions about this condition? Any physical examination finding that you may find difficult to interpret?
Doctor, I have a question.
Yes, go ahead.
Like we see thumb sign on the X-ray when we do. So, do we need
Yes.
to know the signs, or no? They won't be asked in the exam.
Yes, they can ask. They can describe a scenario of acute epiglottitis, and they will mention that what is the most likely finding that you are gonna see on the X-ray of this patient, and that will be thumb sign. Okay, you
Okay,
need
thank
to be
you.
familiar. It
Right,
is very important.
right. Okay, thank you.
No issues. Should we move forward now? So,
Yes, in that epiglottitis, one thing I want to add, in the clinical features, they can mention hot potato voice. That's another
yes,
favorite term they can add in the question.
yes.
Yeah. Yes, Dr. Maruf. Continue.
Now, a 2-week-old male term infant presents to the emergency department with a sudden onset of green bilious vomiting for 2 hours and blood in the diapers. Okay, green bilious vomiting. Right away, we know that the vomitus is coming from the level after the stomach, as we talked earlier. Okay, if it had mentioned that the vomitus is non-bilious, he is just telling you that the vomitus is coming right from the stomach. Okay, so now we know that it is not coming from the stomach. So abdominal X-ray reveals a dilatation of the stomach and in the proximal loops of the bowel. The Barian enema indicates a partial obstruction of duodenum and malposition of cecum. What is most likely diagnosis here? I think it is very obvious in this case. What do you guys think about it? Is it acute appendicitis? Is it malrotation or volvulus? Is it pyloric stenosis or is it jejunal atresia? So the question stem has already mentioned that there is malpositioning of the cecum. Okay, so it is obvious that the answer is malrotation and there is volvulus one. So let me explain that what are we talking about here? So, the malrotation, intestinal malrotation is basically an embryologic disorder. Okay, at this level of teaching, we do not need to know about what exact embryology is going on here. Okay, it has to do with it has to do with physiologic rotation of the gut that is taking place in first trimester, but we do not need to know about it. What we do need to know about it is that in this specific condition, the intestine that are present throughout the abdominal in a normal child, they are not present like that. They are just present at the side of abdomen, most likely on the left side of the abdomen. Okay, and the cecum, which is present normally in the right iliac fossa, it is not now present in the right iliac fossa. It will be present in left side of the abdomen. Okay, so why is this condition important to diagnose? It is obvious that if intestine is malpositioned, it is very likely that the arteries that are supplying those intestine will get disrupted and we will immediately see necrosis of that segment of the intestine. Okay, this is exactly the reason why the question stem mentions that there is blood in the diapers. Okay, whenever there is a blood in the diapers, it means that it is coming from the coming from intestine. Okay, and I have explained it to you why there is blood, because malrotation, whenever there is a malrotation of intestine, the blood supply of the midgut is gonna get disrupted, and we know that if blood supply gets disrupted, we will immediately see necrosis of that segment of intestine. Okay, so As I mentioned earlier, when we see a sudden onset of green bilious vomiting, you should know that the pathology that examiner is talking about is at the level after the stomach. Okay, that may be duodenum, that may be jejunum, that may be ileum. Okay, so one thing I also want you to know about is double bubble sign that is not present in the case of malrotation and volvus, but it is a very familiar exam term that you should know. Okay, the double bubble sign is not associated with malrotation, but it is associated with either
Duodenal atresia.
duodenal atresia or
Duodenal
jejunal atresia,
atresia.
which duodenal atresia. In jejunal atresia, we have triple bubble sign, but we have mentioned it here because these two are very related conditions, because the time frame they present in the emergency department is same. Both conditions will present you in about after 7 days of delivery, or even 2 weeks of delivery, or maybe 1 month after delivery. But it most likely it will be less than 6 months. Okay. Pyloric stenosis, yes, I have mentioned it earlier. Pyloric stenosis in exam would have projectile vomiting as a key feature. So in the case of malnutrition and vulvus, the next best step in management to diagnose this condition would be an upper GI series. Okay, what is an upper GI series? It is an investigation in which we give an oral contrast to the patient, and when he has taken contrast orally, we perform immediate X-ray series of X-rays, and we really see that how that contrast is going through your intestine. Okay, and there is a very specific pattern of contrast that is observed in this pathology, that is corkscrew sign. Okay, whenever you see a word like corkscrew sign mentioned in question stem after an upper GI series, you really have to think about intestinal malrotation. Okay, and as also mentioned in this question, uh, he may just directly say to you that his cecum is malpositioned. Okay, so the investigation that we have to do is an upper GI series, which is basically an X-ray, but it is a video X-ray. Along with, we have to give him oral contrast, and we can just exactly see where the cecum lies, or where his large intestine and small intestine are positioned. Okay. So we will discuss about intussusception later in this segment. We have a dedicated slide about this as well. Any questions about malrotation and vulvus? Anybody? Because this is an important condition you need to be familiar with. So now we're going to talk about its treatment. Because as I mentioned earlier, that the most likely complication that is going to arise is that the blood supply of gut is going to get disrupted, and the bowel may be going through some necrosis, or even it may be even necrosed by the time it presents to you in emergency department. So we have to deal it as a surgical emergency. Okay, we have to follow ABCDE protocol. That is, we are going to secure his airway, then breathing, then circulation, and then disability. But the thing that we are going to do here right away is that we have to decompress his stomach with a nasogastric tube. Why so? Because we need to take out any content that is present in his stomach, to allow be- because you think of it like that, if intestine is already compromised with a compromised blood supply, then we do not really want to burdenize that part of intestine. And the way we can do about very quickly is that we pass an NG tube, and we decompress all of his stomach and take out any gastric content that is present. Okay, in that way there will be no load on that compromised segment of intestine. And depending upon his clinical status and examination finding, we may have to perform even laparotomy right away. So what will be those specific examination findings in which we have to do laparotomy right away? That those are things like he like the examiner will say in the question stem that the patient has signs of peritonitis like abdominal rigidity, rebound tenderness, or even hemodynamic instability. In that case, the most appropriate next step in management of that child after NG decompression would be laparotomy, because that part of bowel is already necrosed. Okay, so we have to immediately take out that part of the bowel so that we can anastomosis those two segments with each other, and we we really hope that he will recover from this condition. So, any questions about malnutrition? Okay. Next question is a 5-month-old child is unable to speak but makes sound. She can hold things with her palm but not with her fingers. She smiles and laughs and is not shy. She cannot sit independently but can hold her hand and sit when propped up against the pillow. What is the best developmental stage to describe this child? So this is a kind of a tough question. Okay, so what are your guesses are here? Like, if he's is he normal? If he's if there is delayed speech or language development, or his only just he's socially delayed, or or his fine motor development is delayed. What are your guesses here? The age of child is just 5 months. So the
It's
development
normal.
of this child, it is normal. Okay, why is that? Because first you have to just look at his age. Okay, the age is his all of that, all of his physical examination findings that are mentioned, all that are normal according to his age. But the way you are going to solve these kind of questions, which I believe they are tough to answer, because we most of us are not familiar with the norms of the physical examinations of a child. So you have to really memorize those normal findings. Let me just show you. Okay. Around 12 months, okay, when we look at the, so first, he has mentioned that the child is unable to speak but make sound. It is perfectly normal for a 5 month to be unable to speak but make a babbling or even cooing sound. Like he or she can make sounds but does not say words or not even say mama or papa like that. And I want you to know that after the child is of 1 year of age, then we can really expect that the child can say words like mama, papa, or even other words other than that. But that is after 1 year of age. Okay. And next, he is saying that she can hold things with her palm, but not with her fingers. So, not with her fingers, we called it a pincer grip. Okay. And that is a feature that you will most likely see after 9 or 10 months of age. And just you can say that it is also present after 1 year of age, that a child can hold objects with his fingers. Okay, but we are not expecting this feature to be present at a 5 months of age. And next, he says that she smiles and laughs and is not shy. It is perfectly normal. uh, we expect our babies to not be afraid, and they are just you all know they are smiling all the time. She cannot sit independently but can hold her hand and sit when propped up against the pillows. Okay. So, when do we expect a child to be able to sit independently? That is after the 9 months of age. Okay. And when do we expect him to take a first step? That is also after 1 year of age. So, 1 year of age is a hallmark for many of the physical examinations for a child. That is, after 1 year of age, a child should be able to say words like mama and papa. A child should be able to take his first step and walk unsupportedly. And He may also demonstrate pincer grip, that is holding objects with their fingers. Okay, so everything described here is normal, and what you need to know about here is that you have to really memorize those features which are present at each age group. I know that it is difficult to memorize those features, right? Because we can easily overlap that age group in those features as present, and you just have to memorize them. There is no explanation for them. There is no physiology to explain here. You just have to memorize these features. And I also want you to know that in your real exam, you may not see MCQs more than one about this topic. Okay, and if you are lucky enough, you may even not see even one MCQs from this topic. But if you do, there will be just a single MCQ about developmental milestones. Okay. So the next question here is, an 8-year-old child is brought to the emergency department with a fractured leg. The parents are unable to explain how the leg fractured. X-ray reveals several other fractures in various stages of healing. I think up to this point, you will be thinking about non-accidental trauma or child abuse, because there are a lot of fractures that are mentioned here. Okay, and also that the parents are unable to explain. Okay, so it is also pointing towards non-accidental trauma. The parents cannot explain what might have caused him. Another feature about non-accidental trauma. But here comes the real deal. On examination, the child has blue sclera and difficulty hearing. This just changes the whole scenario. Okay, what do you think is the most likely diagnosis? Is it non-accidental trauma, which was right up until the last point? Is it Wilson disease? No, I don't think so. It is Wilson disease. Is it hemophilia? No, it is not hemophilia, because there is no hemarthrosis, there is no bleeding in the joint mentioned here. Or is it osteogenesis imperfecta? What do you guys think about it? So the most likely diagnosis in this scenario is osteogenesis imperfecta. I mentioned earlier in our first slide that the only condition that you're gonna confusing non-accidental injury is going to be osteogenesis imperfecta. Okay, because in both of these conditions, there will be multiple fractures in various stages of healing. Okay, but the examination findings are the only things that are going to help you in this case, and that are the blue sclera and difficulty hearing in case of osteogenesis imperfecta. So what is osteogenesis imperfecta? It is basically an inherited disorder of, it is basically autosomal dominant inherited disorder of type 1 collagen that results in very fragile and low density bones. Those bones really break easily, with often with minimal or even no trauma. When I say no trauma, I mean about the bones that are present in your inner ear. Okay, and that is the thing that is going to lead to hearing problem. Okay, there are three bones in your middle ear now: malleus, incus, and stapes, and they are all connected to each other. So if we have those very tiny bones and a very bad type of type 1 collagen, those bones are gonna break apart very easily. Okay, and if those three little bones break apart and they are not connected to each other, we are gonna see hearing abnormalities in those children. Okay, and blue sclera is also gonna present in this case, and the reason is same. Okay, the reason is same, that is the sclera for our eye has normally has type 1 collagen in it. So if the type 1 collagen is faulty, the sclera is also not going to get that nice normal type 1 collagen. Okay, so there is a mnemonic to memorize osteogenesis imperfecta, that is bite. Okay, BITE. You can write that down. B means bone issues. I means, like, you can think of it as EYEI, but the word in mnemonic is I actually. Okay, the T is for teeth. Okay, we are also there is also a subtype of osteogenesis imperfecta, in which we also see the abnormalities of teeth, because teeth also have type 1 collagen. Okay, and E stands for ear, and as I explained earlier, there will also be ear abnormalities will also be present in this case. So the mnemonic here is bite, B for bone fractures, I for ear, T for teeth, and E for your ears. Okay, eye and ears, teeth, and bone. So you only need to worry about osteogenesis imperfecta and non-accidental trauma, and you have to differentiate these conditions apart based on physical findings, which are glue sclera and hearing loss. Okay, so any questions about it? Okay, we should move forward. So we have a 13-year-old girl with several years of elevated liver enzymes of unknown etiology presents to the clinic with a slow deterioration in her school performance. Okay. Now, on examination, there is hepatosplenomegaly, intentional tremors, dysarthria, dystonia. Her urine analysis has elevated level of glucose, protein, and uric acid. What is most likely diagnosis here? So, what do you guys think? Is it
Will,
Wilson's?
will
Is it autoimmune hepatitis? Is it glycogen storage, or is it alpha 1 antitrypsin? Why is that Wilson? Why is that Wilson? Okay, I will explain it to you. In Wilson's disease, the pathology really lies in the transport of copper ions in our body. Okay, the seroplasmin is a compound that helps transfer copper throughout our body. Okay, and the levels of seroplasmin are down because it is the pathology that is causing Wilson's disease. That seroplasmin levels are down, and so copper cannot be transported from your gut to your whole body, like in the liver, in the CNS, in the kidneys. So the pathology there is that the seroplasmin levels are decreased. Okay, so there is a buildup of there is a buildup of copper in in all these organs, and that I'm going to explain now. So first, need to understand that the most common presentation that you are going to encounter with the Wilson disease is that he will mention symptoms of two organ systems. What are those two commonly involved organ systems? One is liver. Okay, he will mention that he has deranged LFTs, or he may even try to trick you by not giving by not mentioning this. He will just simply give you his LFTs, and his LFTs will be in the range of maybe 100, 200, or even 300 international units. Okay, so it is clearly not normal. And the other organ system that is gonna be involved in this case, it will be his brain. Okay, so in brain, the basal ganglia is these are basically the deep nuclei present in your brain that control the intentional movements and the speech that is being generated by the brain. So in basal ganglia, the copper is gonna get built up, okay, because seroplasmin levels are down and it cannot be transported properly throughout the body. So the basal ganglia are gonna get destroyed. So it will lead to extrapyramidal symptoms that are mentioned earlier, that are like intentional tremors, dysarthria, and dystonia. When we will come to the CNS portion of this coaching session, I will explain in details why we are going to see these kind of symptoms whenever the basal ganglia are going to get involved. But for the sake of pediatrics and Wilson disease, you just have to know that in Wilson disease, the extrapyramidal tracts are going to get involved, and we are going to see features like intention tremors, dysarthria, dystonia, and these are three prominent symptoms of extrapyramidal tracts. So whenever the patient may also present with some kind of psychotic symptoms like hallucinations. Okay, so Whenever you see a young child with a deranged LFTs or pathology of his liver combined with the with features like intentional tremors, dysarthria, or dystonia, you're going to think about Wilson's disease. Okay. And the the famous examination finding of the Wilson disease is that we are going to see Kessler-Fleischer rings around the cornea of our eye. What is Kessler-Fleischer ring? It is basically buildup of copper around the cornea, and there is a very beautiful picture of it. It is mentioned here. Okay, so. And the questions may also mention about his behavior, personality change, and in the extreme cases, he may even say that the child gets hallucinations or and he reports delusions or illusions. Okay, so the thing is that not only his extrapyramidal track is gonna get involved, but we may also see psychotic disorders in these children, and it commonly leads to decreased performance at school. Okay, so the diagnosis of Wilson disease, the next step in management that you are going to most likely encounter is that we have to perform serum seroplasmin level initially. Okay, because this, as I mentioned earlier, this is the compound that is not present in the body and it cannot transport copper throughout the body where it is needed. Okay, so it is this the compound seroplasmin that is basically destroyed in Wilson disease. Okay, we can also perform hepatic biopsy to confirm diagnosis, but it is not commonly performed clinically. It is only performed theoretically. Okay, because the diagnosis is so obvious in this case. Okay, and what is definitive treatment for Wilson's disease? We need to give some compounds that will help clear the excessive copper buildup in the iron. What are those compounds? That are penicillamine, trientine, and maybe in some cases zinc. Okay, so there is a very nice mnemonic for it that you guys can write it down. Is that for the treatment of Wilson's, it is 3 copper pennies, 3 for trientine, copper for just a hookup with the Wilson's disease, because whenever you think of Wilson's, you think of copper. Okay, and pennies for penicillamine. Okay, so and the zinc is not very well covered by this mnemonic, but it is mainly because it is you are not gonna see question about zinc. Whenever they will mention Wilson disease, they will expect you to know about penicillamine and trientine. But if you see zinc in the option stem and not see penicillamine trientine, then you really have to pick zinc as a definitive treatment step. And of course, we can perform liver transplant later at the stages if the symptoms are not controlled with these treatment steps. Okay. So, any questions about Wilson's? Okay, we should move forward. So, a 3-year-old girl ingested 10 capsules from her grandmother's medication bottle, thinking it was candy. By the time the child is in the emergency department, she is drowsy, lethargic. Paramedics noted myoclonic twitching. ECG reveals tachycardia and whitened QRS. Okay, you just have to focus about this point here that his QRS is whitened and potassium is elevated. What most likely medication did the child ingest? So this MCQs this is really about toxicology and poisoning, but we have to include this in pediatrics because if we exclude suicidal attempts from toxicology and poisoning, the most likely age group that we are going to see on examinations and clinically is that the the pediatrics age group, they are going to present us with toxicity. Okay, because they are just thinking that these are some sweet candies and they might end up ingesting a lot of them, thinking that they are sweet. Okay, so it is the reason that we have included this MCQs here, just because the most common age group that presents with the poisoning is pediatric age group. So now we come to the real deal. What type of poisoning we are encountering here? Is it nifedipine? Is it thyroxine? Is it acetaminophen? Or is it tricyclic antidepressants. Okay, this is where in these type of MCQs, the thing that is that can help you guys is that your knowledge should be strong. Okay, you are expected to know that of all four options listed here, only tricyclic antidepressants are associated with widened QRS complex. Okay, neither acetaminophen is associated, neither thyroxine, or not even nifedipine. So the widened QRS, it is so important in the case of tricyclic antidepressant overdose that the only treatment we give to these patients is sodium bicarbonate. Okay, why we give sodium bicarbonate to these patients who have ingested tricyclic antidepressants? It is because sodium bicarbonate stabilizes our cardiac membranes, and if with the electrolyte abnormality present, there is a very less chance that this abnormality will be converted into lethal cardiac arrhythmia such as ventricular fibrillation or even ventricular tachycardia. Okay, so the other clinical features that would be associated with tricyclic overdose, it will be, I have a mnemonic for them, it is called anti-ham features. What is ham? It is H for histamine, antihistaminic effects, and A for anti-alpha effects, which essentially means that there will be a hypotension that will be present in this patient, because alpha receptors that are present in our blood vessels, they are going to get blocked, and we are going to see hypotension in these patients. And what is M? Anti-M. It means that anti-muscarinic features will also be present in patients with TCA's poisoning. Okay, so anti-ham features will be present whenever you will see TCA's poisoning, along with the very prominent feature of widened QRS complex, or even he will say that his QT interval is prolonged. Okay, so along with finding of hyperkalemia, but this is not directly associated with TCA. It is indirectly associated with TCA, and what you should focus on is that you should know that TCAs are associated with the widened QRS complex. Okay, so in the presentation, the child will be lethargic, drowsy, and he may have coma or seizures. The reason for this presentation is that the TCAs have anti-muscarinic properties in them, and it makes them lethargy, drowsy. As you guys might know that. Let's just discuss the features of anti-muscarinic poisoning. So, what are these features? Uh, the first of all, the patient would be lethargy and drowsy because the muscarinic receptors are present in CNS, and if they are antagonized, we will see lethargy and drowsiness. Secondly, we will see there will be flushing of skin, and and his skin would be just dry and red, and his heart will be in tachycardia because muscarinic receptors lead to just it is basically parasympathetic nervous system that is basically antagonized. So we know that normally parasympathetic nervous system leads to bradycardia, and if we antagonize it, obviously you're gonna get tachycardia. Okay, so the diagnosis here, it is just based on all the features that we talked earlier, and we just have to perform ECG to just check for that QRS complex interval or even QT's interval. Okay, and we can also perform ABGs to rule out respiratory involvement if the drowsiness is so severe that his respiratory system is getting depressed. And obviously, we can perform toxicology screen to just confirm it. Okay, and regarding its treatment, there is a general principle to be known is that if the ingestion takes place in past 1 to 2 or even maybe 3 hours, and then we can give him activated charcoal to flush his gut. Okay, but if the patient is presenting late after 5 to 6 hours, then we cannot proceed with activated charcoal. In that condition, we just have to focus our treatment on correcting that QRS complex abnormality. Okay, and I mentioned earlier that the only drug that is available to us for correcting that abnormality is sodium bicarbonate. Okay, it just stabilizes your cardiac membrane so that the prolonged QRS is not converted into lethal ventricular arrhythmia such as ventricular fibrillation or torsitis de Pontes. Okay, are you clear on this? These are basically features that are associated with TCAs, and we call them anti-muscarinic features. And as I mentioned earlier, that you are going to get see dry flesh skin, and I forgot to mention about the other that are dilated pupil. Uh, you just have to think about that whatever the parasympathetic nervous system does in case of TCAs, all of that going to happen in the opposite direction. Parasympathetic nervous system constricts your pupil, you're gonna see dilated pupils as well. Okay. Uh, and parasympathetic makes secretions such as salivation or even lacrimation. So all of that is gonna get blunted, and you're gonna see dry mouth, dry skin, and obviously urinary retention also, because parasympathetic is the system that controls your urination, and so you cannot really urinate in that condition because that is all that autonomic system is blunted. Okay. So there is just only one thing that I would expect, and the examiner is going to expect from you to know about TCA poisoning, is that it involves cardiac membrane due to electrolyte abnormality, and this would lead to prolonging of QRS complex. And the treatment is also just to focus correcting that abnormality with sodium bicarbonate. Okay. So the next scenario, a 3 month a 3-month-old female baby presents to the emergency department with difficulty in breathing. On examination, she has intercostal recessions, okay, and bilateral widespread V's. Her temperature is almost 38 degrees Celsius, and her respiratory rate is 35 beats per minute. What is most likely diagnosis? So, what do you guys think about it? Anybody who can take a guess about it? Hello. So, in this case, uh, the thing that is going to help you navigate through this,
Bronchiolitis. Sorry.
yes, it is bronchiolitis.
Okay.
It is bronchiolitis. But you are going to reach to this diagnosis by just focusing on physical examination finding. Okay. The only physical examination finding associated with bronchiolitis is bilateral widespread V's. Okay, as the pathology states that it is a pathology of bronchioles that are present in our lungs, and whenever there is pathology of bronchioles, they are gonna get constricted, and there is inflammation going around in those bronchioles, and they are gonna get constricted. If they are gonna get constricted, then we will see wheezing on physical examination finding. And I want you to know that other apart from bronchiolitis, you will see wheezing in on a child in a diagnosis of asthma. Okay, but we have not included in this in these options because it is very difficult to differentiate two conditions apart. Okay, because both are immediately diagnosed in emergency department based on physical examination findings. And bronchiolitis can be, you can say, differentiated from asthma based on just a fever that will be described in this question bank. Okay, and also about the history of presenting illness. Okay, what will be history in case of asthma? In case of asthma, the mother will say that the child has a fever, sorry, history of prolonged cough and nighttime awakenings due to respiratory distress. But in case of bronchiolitis, you know that it is an infectious illness caused by a respiratory syncytial virus. So in that case, there will be no history of chronic symptoms. The child will present acutely, but not that clinically unstable, or and it is basically not a fatal condition, like we talked about acute epiglottitis earlier. Okay, it is just a mild viral infection that is we have to diagnose based upon physical examination finding. And if we talk about its treatment, the treatment is basically supportive here. There are no antibiotics that need to be given here, no antivirals that need to be given here. Just we have to supplement the patient with oxygen, and maybe we do a suctioning, or maybe we even nebulize clinically, but no treatment is needed apart from that. Okay, so the take-home point about bronchiolitis is that on examination, you will encounter bilateral V's along with a low-grade fever, maybe 39 or even 39.5 degrees Celsius. Okay, and the child will appear clinically stable. He will not give you a toxic picture like that he will give you in case of acute epiglottitis. Okay, so and other symptoms of cough and mild itchiness or even sneezing may also be present, but not always. Okay, anything you need to know about bronchiolitis, or you have in mind asking about it? So we move to the next question. A 3-year-old boy is brought to the accident and emergency after having a generalized tonic-clonic seizure that lasted approximately 5 minutes. Okay, the parents say that he was previously well, but started developing symptoms of cold earlier in the morning. He is noted to have a fever of 39 degrees Celsius. What is most likely diagnosis here? Is it epilepsy? Is it partial complex seizure? Are these febrile convulsions or infantile spasms? So right
Febrile
away you know that.
convulsions.
Yes, what did you say?
Febrile convulsions.
Yes, obviously, these are febrile conversions, but we have to first exclude other options. That why is not epilepsy? Because whenever there is fever, you can never, ever, ever diagnose epilepsy if there is fever. Because epilepsy is only diagnosed if we have excluded all other conditions that may lead to seizures. Okay, so it is really irrelevant here. These are not partial complex features because he has clearly mentioned in his question stem that he's having generalized tonic-clonic seizures. Okay, the partial complex are not generalized in tonic-clonic. Okay, and infantile spasms, that is also basically irrelevant here, and it is clearly not associated with fever. Okay, so what are febrile convulsions? This is basically a very benign clinical condition. It may look like to you that the patient is having generalized tonic-clonic seizures, and you may guess that he has a very serious underlying pathology associated with it, but it is not the case. Okay, it is a very benign clinical conditions with almost no impact on health of the patient after he is recovered from it. And it is the seizures are only there because his body temperature is high. Okay, the thalamus of the hypothalamus and thalamus of a child is not that developed maturely as it is developed in an adult. Okay, so in a case of child, when a child gets a fever or a high grade fever that you will encounter on exam, that high fever is going to disrupt hypothalamus and thalamus. Okay, that disruption is going to lead to these generalized tonic-clonic seizures. The pathophysiology here is not clearly written in books, and you are also not expected to know pathophysiology, but you are expected to know that whenever there is a high grade fever in a child, it may lead to generalized tonic clonic seizures. And the other thing that you are expected to know is that the specific characteristic of these seizures. And what are those characteristics? These are the characteristics that the seizures will be generalized. Okay, if the seizures were localized and present in only one part of one part or half side of a body, then you cannot say that these are generalized, and these are obviously then not febrile seizures. Because in order to diagnose febrile seizures or febrile convulsions, you got to have those generalized tonic-clonic seizures. Okay, And the other feature is that the episode of these seizures. In case of febrile convulsions, there will be only one episode of these fever that will be present in 24 hours. Okay. So if there is a case in which the question in which the examiner describes that the child is experiencing maybe two or even three episodes of generalized tonic-clonic convulsions in 24 hours, then you can easily exclude febrile convulsions there. Okay, because I told you that in order to diagnose febrile convulsions, you really need to have just one episode of seizures in 24 hours. Okay, and that episode is gonna last somewhere around 5 minutes. Okay, so these are the three features that are associated with febrile conversions. So there are I also want you to know that there are also two types of febrile seizures. Okay, one is simple febrile seizures, and the other is complex febrile seizures. Okay, so when we talk about simple febrile seizures, these are the seizures that last less than 15 minutes, and complex one obviously will last more than 15 minutes. Okay. The reason that we are gonna categorize these seizures in two categories is because it affects our management. What is the management in this case? The management is that if the seizure is complex, then we may need to give an anti-epileptic agent or even a benzodiazepine to that child to terminate seizures immediately, because if it lasting greater than 15 minutes, it may permanently damage his brain cortex. Okay, and you may also encounter questions related to its clinical outcome, like if a patient has come to your emergency department with the febrile seizures, and the examiner wants you to know what will be the most likely outcome in this of this condition, or even parents would ask that after your treatment, that is our child gonna experience those seizures again? And you have to know that one in three children can experience these episodes again in their life. Okay, so if a child has an upper RTA infection and he gets converted and he experiences febrile seizures, and in that case you can assume that there are 33% chances that again later in his life, if he has an upper RTI leading to a fever, he can there is a 33% chance that he can again experiences those seizures. But the thing here to know is that this is not the pathology you need to worry about. These seizures are simply subsided with treatment like antipyretics. Okay, like paracetamol, acetaminophen. Okay, so, and one other point I would like to mention here is that about one in three who have further episodes would develop epilepsy later in their life. Okay, so this is all. You also need to familiar with this, that epilepsy means that the seizures that occur out of nowhere with maybe even physical or sensory stimulus, and they are not associated with any obvious pathology. Like if you perform CT of his brain, you perform his electrolyte abnormality, you perform all his blood tests, and no pathology shows up. Only in that case you can diagnose him with epilepsy, and epilepsy is kind of associated with febrile seizures. Okay, so treatment, as I mentioned earlier, that in whenever you see febrile seizures, the only thing that you're gonna need is antipyretics. And if the seizures last more than 15 minutes, then you can try giving him benzodiazepine or even anti-epileptics. Okay, because in that case we can say that these are complex febrile seizures. Okay, so any questions about febrile convulsions? Okay. Now we have a 4-year-old girl attends clinic with a history of diarrhea, bloating, abdominal pain. She is failing to thrive. Focus on this word here. Failing to thrive. Blood tests reveal hypochromic microcytic anemia. Alpha gliadin antibodies are positive. What is most likely diagnosis in this case? Is it ulcerative colitis? Is it Whipple's disease? Is it pernicious anemia? Or is it celiac disease?
Celiac disease?
Yes, you are absolutely right. As you might expect that in a case of ulcerative colitis, you would see bloody diarrhea, which is clearly not present in this scenario. And Whipple's disease is it is not a disease of pediatric age group. You just have to know about it. So, and pernicious anemia, it is also not a pathology that is that you are going to associate it with pediatric age group, because the autoimmune conditions are generally present in middle age group. Okay, there are some specific autoimmune conditions that are present in pediatric age group. Celiac disease is one of them, but not pernicious anemia. And the type of anemia that you are going to see in the case of pernicious anemia is going to be macrocytic anemia. Okay, if you look at the question stem, he mentioned that he has hypochromic microcytic anemia. Okay, so it is microcytic anemia. So we can easily exclude pernicious anemia also. And I also want you to know that what does hypochromic mean here? Okay, what is the meaning of it? What is hypochromic microcytic anemia? Anybody?
Hypochromic means that HB is low because of the lower iron content.
Yes, 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 yes. You are absolutely right. Whenever there is low iron in our body, you are gonna get these nice hypochromic microcytic red blood cells in our peripheral sphere. Okay, and whenever you talk about celiac disease, that almost every patient is gonna experience is that he is gonna get low iron levels. Why is that? It is because the celiac disease is an autoimmune condition that attacks basically villi and microvilli of your small intestine. Okay, so the thing here to know is that in celiac disease, the most likely region of the intestine that is going to attack by your own T cell is going to be your duodenum or jejunum, or even in severe cases, it can be ileum, but most likely in 90% cases, it is duodenum and jejunum. And I also expect examiner also expect you to know that iron is absorbed basically in duodenum. Okay, there is a very famous mnemonic for it to memorize that what vitamin or mineral is absorbed in which segment of intestine, and that is iron fist bro. Okay, so what does it mean? Iron means iron. It is absorbed in first part of in small intestine, that is duodenum. Okay, the second is jejunum. What is absorbed in jejunum? That is iron, and that is F for fist. What does F mean? It means folate. Okay, so folate is absorbed in jejunum, iron is absorbed in duodenum, and third word of mnemonic iron fist bro. B is for basically B12. Okay, so whenever and that it is basically in the third place due to the fact that ileum is the third segment of your small intestine, and whenever there is pathology of ileum like in Crohn disease, you're gonna get disruption of vitamin B12 malabsorption. Okay, so in celiac disease, the pathology was really in duodenum and jejunum. So you are gonna get disruption of iron absorption, which will lead to microcytic hyperchromic anemia, which along with presentation of diarrhea should really clue you in towards the diagnosis of celiac disease. Okay, because diarrhea is gonna be almost present in case of celiac disease. Okay, it is very unlikely that examiner expects you to diagnose celiac disease in the absence of diarrhea. Okay, so diarrhea combined with iron deficiency anemia along with failure to thrive is really hinting you towards celiac disease. Okay, these are keywords that are going to help you diagnose celiac disease, because celiac patients, they have a chronic history of inflammation in their body, which will really drive them and lead to their decreased BMI levels and decreased percentile of their weight. Okay. And I also want you to know that celiac disease is one of those autoimmune conditions that can be diagnosed in pediatrics age group, but also in adulthood. Okay, we can also see patients of celiac disease not only in just age of like 2 to 10 or 15 years of age, but we can also diagnose it in later stages of their life, like in 30 or 35-year-old male may present with all these symptoms, and you can also consider celiac in that case also. Okay, so uh, in when we talk about autoimmune diseases, we just have to simply memorize that what antibodies are associated with what condition, what antibody is associated with what condition. So in case of celiac disease, I want you to know that we may see raised level of IgA tissue transglutaminase antibody and IgA anti-gliadin antibody, or even anti-endomysial antibodies. You just have to memorize these three names, and on definitely if it is an pathology of small intestine, we can always confirm our diagnosis with the biopsy, but that is not done clinically. It is mostly diagnosed based on titers of IgA. And one thing I would also like to mention here is that the patients with the celiac disease are for God knows what reason, are associated with the IgA deficiency. IgA deficiency is basically an immunodeficiency, but it is associated with the celiac disease. The 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 thing that I'm trying to teach you here is that consider that a patient has a celiac disease, okay, and we are expecting that we might get raised titers of IgA tissue transglutaminase antibodies. Okay, and let's say I performed the level of these antibodies, and these came out completely normal, but the clinical suspicion was very high. What is the reason for this test being normal? Is that the patient with celiac disease are often associated with IgA deficiency. It means that the IgA levels in those patients are really down, or even normal in some cases. So in that case, we have to perform these antibodies based on IgG testing. Okay, so if these patients come and we perform IgA antibodies and these are normal, the next thing you're gonna do is perform IgG of tissue transglutaminase or anti-gliadin or even anti-endomysial. If you have to really pick of all out of three antibodies, which is very unlikely, you can pick anti-endomysial antibody, because of out of these three antibodies, only anti-endomysial antibody is that has very high specificity, around of 90% is and it is associated with the celiac disease. Okay, and the treatment which is performed in this case is that you just basically ask the patient to stop consuming any product which contain gluten. Okay, which so we have to stop his consumption of rye, wheat, barley, because this is where the pathology starts. Whenever patient eats any of these products that contain gluten in them, so his immune system will attack his ingested gluten, and in that process his small bowel is gonna get destroyed. Okay, any questions? So the next question that we are going to discuss is just I need to just erase it. Okay. So this is going to be our last slide that we're going to discuss in this session, and it is going to be about physiologic versus pathologic jaundice that we experience commonly after a child is born. Okay, So here we go. A mother calls the postnatal ward with concerns of her newborn. Her newborn was born at term with an uncomplicated vaginal delivery in birthing center yesterday evening. The baby is feeding well and not irritable. Okay. The parent's first child and the parents are especially concerned as the baby has yellowish coloring of his skin and eyes. What is the most appropriate management here? Is it that we reassure the patient? Is it that we advise to return to the hospital to be seen immediately within next 2 hours? Is it that we inform the community midwife, or is it that we have to manage him on outpatient basis? So, what do you guys think that we have to do here? The thing here is that this child has jaundice in the first day of his life. Okay, so this is a scenario that in which the examiner is gonna expect from you that you should know the difference between pathologic and physiologic jaundice. And believe me that this is so much common clinically. We see all that basically every child that is born, we are expecting him to be jaundiced after like 2 or 3 days. But the real deal here is that if a child is born and we see jaundice in him in first 24 hours of life, then that jaundice is basically pathologic jaundice. What do I mean by pathologic jaundice? And as it opposed to it, what is physiologic jaundice? So the thing here is that the RBCs of a newborn are very fragile, and the levels of an enzyme called UGT glucuronide transferase, which is basically an enzyme that conjugates the bilirubin. It, the level of these enzymes are really down in a newborn. Okay, the enzyme is present there, but it has not yet achieved that level that is present in a child of 2 or even 3 weeks of age. Okay, so the unconjugated bilirubin is compiled up in blood of this newborn, and it leads to jaundice, which is totally normal. We see this jaundice all the time, and and in this question, we are expecting you to know that what are those features that are gonna separate the physiologic jaundice from pathologic jaundice. Okay, so the first feature is that the timeline. Okay, if if the patient has jaundice in first 24 hours of life, then you should safely assume that it is not physiologic, because physiologic jaundice is gonna always present after the 24 hours of life. Okay, and the pathologic jaundice it is needed to be taken very serious, and we have to perform a lot of investigations to find out what is the exact cause here. But in this question, we are not focusing on those investigations. We are only focusing on the difference between these two conditions. Okay, and we may need to perform the level of six G6PD, or but basically first we will perform complete blood count and peripheral blood smear, and then blood grouping, and then Coombs test, and then according to results of those tests, we may further refer to investigations like G6PD levels. Okay, so the real deal here was that if it presents within 24 hours, then it is pathologic. And the other thing which is not mentioned in slide but is very important to know is that if the levels of bilirubin reach greater than 15 milligram per deciliter, it is also out of the range of physiologic jaundice. Okay, physiologic jaundice is gonna always less than 15 milligram per deciliter. Okay, and the management is obviously different for each of the pathology associated with this condition. And but in case of physiologic jaundice, the only treatment that we give the patient is phototherapy. Okay, because it is gonna repolarize those unconjugated bilirubin molecules and making them more water soluble, so that this excess bilirubin is not getting piled up in his brain and lead to permanent neurologic dysfunction. Okay, so I think we have completed our session for today, and I would expect that you guys have any questions about this session you might want to ask?
We
Anybody?
request we request all the doctors, you can, if you have any queries from the above questions, you can ask Dr. Maruf here. Um,
Dr. Maruf, can you share the developmental milestone slides in the group?
I will share the slides in the group. You can memorize them. But let me see.
Also,
I will not share the slides, but I will share these topics from my book. Okay, I have basically extracted this material from a book, and I will share that milestones from a book. Okay, so you can completely get a knowledge of what those developmental milestones are, because we have not written all of them in this slide, and in that book these are written in very detail.
we will definitely share the milestone chart, doctor. So don't worry. We'll
Thank you,
send it
doctor.
over the chat. Thank you so much for all the doctors who have joined. We would request you to put a feedback in the group, in Dr. Afreen's academy group. There are two groups, group 1 and group 2. So we would request you to come back with a feedback on the group. And also, we will be having our discount until this weekend. Please avail the discount and join our crash course. Also, joining the crash course regularly will have a benefit of having to attend Dr. Afreen's classes. Dr. Afreen Sheikh will be taking the classes on OBGYs and all the important topics as well. So the next mock test or the next class is going to be in upcoming week. Stay tuned on Dr. Afreen's Academy group and we'll be posting the updates there.
Thank you so much.
Thank you so much, doctors. Take care. Bye.